Yes.
Okay, great. And you can hear me okay?
Yes. Thanks so much.
Okay, fantastic. So grateful to be here, and I want to thank you so much for inviting me, and to the staff and Mr. Bensky for setting up all the details. Um, it's really fun, especially to be here speaking to you folks at Zucker, because we've had the good fortune of recruiting a number of your excellent graduates to our pediatric residency program. So I'm aware of how excellent their training was and the passion that they learned here at Zucker really enriched our department and our patient population. So it's terrific. And then we're also really grateful because they linked us to folks in your faculty when we were in the early stages of our own curriculum reform process. And we reached out to learn about your program and have adopted a number of elements from Zucker into our program, including early EMT training that we just rolled out recently, in which our students are really appreciating. So that's exciting. So let's see, I've been working in this space for about 24 years, as Samara mentioned. And in the past 3 years, I took the job of Director of Equity and Justice and Curricular Affairs. And it's been really exciting ride. Essentially, I'm the health equity theme leader for our school. And at the same time that we developed my job, we started a fellowship program for 5 students. So it was kind of in recognition of the extensive work that our students were already doing in reforming our curriculum towards equity. And as we were just saying in a meeting a few minutes ago, our students often tend to be ahead of the faculty in some of these areas. So over the past 3 years, I work with 5 Justice and Equity Fellows who each work with me for a year and who receive a stipend to do this work on our curriculum. So that's been really exciting. So it's gonna be a bit of a whirlwind trying to review a lot of the work we've been doing to develop our health equity curriculum, which we started with a focus on anti-racism. And I've added as many references and tools as possible on the slides as I go. And so I believe it's Samantha who's gonna drop in some of these links so that you can learn more. I know there's been a tremendous amount of work already done here at Zucker, and I'm delighted to be partnering with a number of faculty members here, particularly Dr. Doherty and Dr. and Alice Fornari on a lot of great stuff. But I'm hoping that maybe there'll be a few new concepts here that folks can learn about. So I'm going to start by speaking about how to frame these efforts. It's really, really critical to set an environmental tone. When we began this work, there was a tremendous amount of anxiety, both among students and faculty. And so getting in touch with this, really honoring this and setting up a climate to have these conversations is really crucial. We need to foster a safe and non-punitive environment, and at the same time setting some expectations at the top. So I've really tried to think of this as a long-term plan, early adopters, kind of middling, and then benchmarks along the way. Then I'm going to talk a little bit about some inclusive teaching tools. I'll go into our anti-bias training teaching curriculum in a little bit of detail, and then touch upon what we've been doing in terms of our curriculum reform. I just want to acknowledge some of my partners in this work. This has been a huge team effort, and I could have never done it alone. Doctors Laura Benoit and Chris Travis are 2 students who really spearheaded a lot of this work, particularly our anti-bias curriculum work. The Justice and Equity Fellows I work with every day on this, and then many other VPNS students and faculty members have been really, really deeply involved. And then Dr. Monica Lipson, who's our vice chair for education, and she, some of the slides are actually from a presentation that she and I did recently. So when thinking about setting up the conversation, and it's one thing that I think I would say is the biggest takeaway from my past 3 years, is that preparation is key. I've had thought about these topics really since I was a child, but really never thought about how to create an environment to have these discussions. How do we have the dialogue around race and racism? And that's really something that I've been very, very excited to learn more about. So, everybody is familiar with norms. This is one of my favorites. What we learn leaves the room, what is said stays in the room. So kind of a confidentiality statement. And usually these norms are co-created with the learners at the time. But another one that we often use is, everyone has different levels of familiarity and comfort in discussing race and racism, but we're all here to learn. Then we have been consistently rolling out this or introducing this Courageous Conversations framework, which is, we have norms that we've used just in general, difficult conversations. These were created specifically around for conversations around race. This is Glenn Singleton's Courageous Conversations work, and here's his website. So the 4 rules are kind of speak your truth, stay engaged, and particularly because the stay engaged piece is particularly because conversations around race and racism are known to cause kind of a negative emotional valence in most people. So we want to be aware of that and kind of fight against that as we try to make inroads in this area. Accept and expect discomfort and strong emotions. So rather than waiting until these issues and conflicts come up, really saying we're going to get there. This is where the learning takes place. And then, when the group of inevitably gets there, you can stop and say, aha, here we are, rather than kind of being totally blindsided, which I have to admit I've really been before this last 3 years, blindsided a number of times when conflicts came up. And then accept and expect lack of consensus. So it's not about, coming to a kumbaya moment, but really being able to listen to each other. And this comes to my first drop in the chat link, which is we talked a lot to Stephen Brookfield, who has a wonderful book called Becoming a White Anti-Racist. He is a specialist in adult learning theory and an educator. And when he came to do faculty development with us, I think one of the quotes that stayed with the faculty the most was, you can talk about racism badly or not at all. So I just want to share that with you, and feel free on his website. There's a lot of great resources. So I want to just stop and take a moment to do a little exercise that we do together to try to think about the emotions that come into play. So this is called a mood meter. And so the prompt is, when you think about talking about racism or anti-oppression, how do you feel? So identify a word for yourself. So I'm going to ask everybody to do that. Identify a word for yourself from these 4 quadrants. And if you're comfortable, write the word or even just the color of the quadrant you identify in the chat. Let's take a moment to do that. Great, so we have some blue. A lot of, so in the blue, kind of low energy, low pleasantness, sad, nervous. Some yellow, excited, motivated, nervous. Red, yellow, and blue, so all at once. And again, it may be different, because we're actually doing this work today. Disheartened, uneasy, red, frustrated, troubled. Great. Okay. So thank you for participating in that. And got a couple more. Motivated, curious. I love that. Thank you. Yeah, optimistic, grateful. Great. So, and a mixture, of course. Great. So it's a nice exercise. We use it with our students, and really just kind of trying to focus on, an awareness. Again, discomfort is how we learn, but it can also turn us away from learning. So we want to be mindful. Okay, so this is actually one of the slides that Dr. Lipson put together. So just an acknowledgement that this area that we're speaking of today is really evolving. There's so many different paradigms that are contributing to this work: ethnic studies, Afrocentric education, critical pedagogy, critical consciousness, critical race theory, cultural competence, anti-racist pedagogy, anti-oppression pedagogy. So really a lot of different ways that we can think about this. And then over here on the right, it's just some frames from Clarence Braddock. We think about minority affairs, diversity inclusion, et cetera, anti-racism. So really a spectrum there. And I'm kind of, coming from many of these areas in talking about this today. Many of you are aware of this opinion piece from the Wall Street Journal, which in many ways was, I think, helpful. Medical education goes woke. So really, some folks' response to this kind of work that we're doing, really kind of saying, this is really just PC language and woke behavior. And it's really, using this has really been helpful in terms of sharpening our focus on what are we about. Is really not about being correct. It's really about science and educational rigor. And we'll talk more about that as we move forward. And this is a really useful conceptual framework that we're using. It's a recently published framework for developing anti-racist medical educators and practitioner scholars. And so just kind of really a roadmap. So really focusing on the foundational awareness, foundational knowledge, then embedding anti-racism education into practice, and then moving towards action, dismantling structures, et cetera. So I encourage you to look at that. When I look at this pyramid, it reminds me that, a pyramid is built on solid foundation. And even below the pyramid is the environment that we have to cultivate in order to build anything. So I'm going to just kind of stick with that environment for a few minutes before moving forward. So how do we foster an inclusive learning environment? So this is, I thought we'd start with a vignette, and this is a kind of a more participatory exercise. So this is a student from our institution reported this to the diversity office a number of years ago now, before I think we had our feedback portal open, but I think it's something that could still happen today. And I really like it because I think it's something that I could easily, maybe not about football, because I don't know anything about football, but something very similar that I could do. So the student said, while on my ex-clerkship, after presenting to an attending, he responded with a football analogy that I did not understand. So the student asks more about that analogy, and then the attending's reply is, "Oh, I'm sorry, that's right. In your country, it's the other football, soccer, right?" I had never worked with this attending. He knew nothing about me other than my name and what I looked like. So what I want to ask this group is, did this attending cross a line? And if so, what was it? And if you feel comfortable responding in the chat. Oh, yes. And in response to the last chat, I will be sharing these slides, so don't feel like you have to write everything down. Absolutely. So what do folks think about this? Okay, we have yes, inappropriate, based on looks. The attending assumed the individual is not an American. This is a microaggression. Why assume he's from another country? Okay. So it's a microaggression. And I guess I think that you are agreeing, are you kind of, well, I guess how might the student have been feeling and why? I think you started to answer that question. So it's a microaggression, but it's also a cognitive error. Right. It's a cognitive error in that it's in that assumption. Mm-hmm. And so how might this student have been feeling as a result? Okay, othered. Mm-hmm. Thank you. So kind of feeling outside, being stereotyped. Mm-hmm. Exactly. And I'm going to move to why me. Agreed. The student felt likely othered. Mm-hmm. And I want to move to the next question, which I think is a very important one. Why might the attending have responded in this way? And again, this is something that I could see myself doing, something very like, what was the attending thinking? Mm-hmm. His life experience is leading him. Maybe he hasn't met a lot of people who look like this student who are from America. He's trying to connect with the student. Yeah, he's trying to make a connection. He's trying to establish rapport. He might be trying to establish rapport. Absolutely. Right? He didn't say like, oh, you're an idiot if you don't understand football, right? He's trying to connect. So whether he has limited understanding of human diversity of emotions, he might have some implicit bias, but he also is maybe making an assumption based off his limited experience, limited social skills, trying to make up for it. Sure. And we're not all the most socially adept, and we could still be really good doctors. So great. Thank you so much. Great. And that happens to all of us. So, but just, I think you started to speak a little bit about the othering. So just to get back a little bit to this concept and where it fits. So I think most of the folks on this call are aware of this, but our desire to conform to the standards of a group are very powerful. Maslow's hierarchy of needs, talks about the physiological needs being deemed the most fundamental. However, belongingness is also a core need. And this need begins with our helpless infant state and continues throughout adulthood. And countless studies have demonstrated the primacy of belonging in human behavior and decision making. In fact, I think what we found out by science is that being excluded from a group actually triggers activity in the same regions of the brain that are associated with physical pain. So something for us to keep in mind. I really appreciated the opportunity to think more about how I, may or may not be creating a climate of inclusion for my students. So what are some consequences for these students who may be experiencing these types of events? And again, there's so many more dramatic stories shared by students, but I like this one because I think it's something that I can at least really, I think many of us can see ourselves doing something like this. But in the spirit of fairness and justice, right, we want to treat our students fairly. We want them to be able to learn from us. This consequent of stereotype threat, I think everybody here is familiar with, but just to review. So particularly if the student is from a minoritized group, stereotype threat refers to the fear of confirming a negative stereotype about a respective in-group. And this fear has been shown to create high cognitive load and reduce academic focus and performance. The effects of stereotype threat can be profound, and multiple studies have found that stereotype threat significantly reduces performance for undergraduates from less privileged socioeconomic status, African American and Latino students, women in math and science courses, and LGBT students at traditionally religious institutions. Most of the work has been done in undergraduate students, but we can see that this would be very relevant for us as well. Fear and low self-worth, in addition, if this were a minority student or a minoritized student, and then even if it was a majority or a privileged student who was witnessing a microaggression or an incident of bias, very likely all students might feel confusion, disillusionment, cynicism, burnout. So, we know our trainees are struggling with transitions to new environments, new learning environments, and these students from less privileged and more marginalized backgrounds face even greater challenges. And I know folks here are very aware of that. Just to review, like environmental challenges to belonging, we have our daily professionalism issues and mistreatment, both of which are, may be reflected on our GQ or graduate questionnaire. There's the fact of segregated care within our learning environments. There's an element of hazing that we know goes on in the hospital, and we talked about stereotype threat. And just to reiterate, particularly when we're thinking about competency-based education, which is, I think, something that we are really focusing on in our curriculum revision, and I imagine you are as well, psychological safety is a crucial component of team functioning and learning. So we don't want to lose sight of that. Benefits of an inclusive learning environment: increased sense of belonging, increased participation, increased performance, improved patient care, healthy students. And I'll just talk a little bit about scientific innovation. This is Marie Bernard at the NIH. This is her paper where she talks about the need for diverse perspectives in science, and actually has quite a bit of data demonstrating that the more diverse a team is, or scientists are, the more innovation is happening. And she this is her picture with, all these various folks viewing the elephant from their own different perspectives, and presumably providing innovative perspectives that way. So what can we do? A couple of tools. One is, and this is if Samantha, if you could drop this, there are two tools in the chat. One is an article called 12 Tips for Inclusive Teaching that I found very helpful. And a second is at the Center for Teaching and Learning at Columbia. They have some really, really wonderful and innovative tools, some videos. I've used them quite a bit for faculty education. So there's even just like 2-minute videos. And if you can't find them, let me know. Happy to share. Tip 2 from this 12 tips is embracing a growth mindset. And I'm going to talk a little bit more about how we're doing that at VPNS. And tip number 5, so these are my 2 favorite tips, is make a personal connection. So even just taking 1 minute at the start of an interaction to welcome the student into the space, to ask them about themselves, if you have time, share a little bit about yourself, really something as brief as I'd like to know a little bit about you and your interests. We want to make sure that we're modeling kindness and compassion. Obviously, we are, by definition in our profession, dedicated to the relief of suffering, but we want to find ways to make that explicit for our learners. So I'm going to jump, speaking of growth mindset, I want to turn towards our curriculum. This particular curriculum is just called Promoting a Bias-Free Curriculum. And again, this was created through students partnerships spearheaded this. And so there's 3 kind of prongs to this project. One is the bias-free curriculum. The second is an anonymous feedback portal where students can give feedback to faculty on their teaching. And the third is kind of a structural way to prompt our faculty to think about this curriculum and this process. And so I'm going to go over all those 3. And Samantha, if you could put the link in the chat for the bias-free curriculum, and just if you Google bias-free and VPNS, it'll come up. So I'm going to go through all of these in a little bit of detail, because I think, just to give some materials and tools that we're using to think about these various things. And we just revised this. So the social construction of race runs through all of these. And then I'll go through each of these in turn. So first is just the social construction of race. I'll give an example. This is an example of a slide from a lecture that we had. So schizophrenia described in all races and geographic areas. Incidence and prevalence vary throughout the world. Female to male ratio 1 to 1.4. Any thoughts here about what race means in the context of this slide? And is there a way that this faculty member, if you're reviewing this slide, we might be able to help them to be a little bit more specific or explicit about the way race is used here? Thoughts? I'm wondering, yeah. Any thoughts about how we're talking about race in this particular slide? Okay, perhaps using people rather than races described in all people and geographic areas. So I think, one of the things our students kind of tried to do is to go through, and I know a lot of medical schools have done this, kind of really try to look at when the word race is used, can it be misconstrued in any way for the learner? Yeah, so it's not really useful on this slide, right? Because you could say described in all geographic areas and in all people, right? And so anytime we're being imprecise, we can, our learners can misconstrue. Consider how racism may impact the diagnosis of schizophrenia, right? And that's even taking it to the next level. And race, we know, has been used. Black people have been been diagnosed in much higher levels with schizophrenia. So that's a really useful teaching point that we can delve into, especially in psychiatry, and we're doing that. So anytime you're bringing up race, and it can be, somebody could misconstrue this to support a biological theory of race, then we want to try to stay away from that. Such a complicated concept to understand. And again, there's a nice, and this is another thing to drop in the chat, there's a nice thing on YouTube video called Race, the Power of an Illusion, where they really start to try to tease out this concept, but it really is confusing, the idea. Race, ethnicity, ancestry, and I've sat in at least a couple of meetings with very, very accomplished faculty, experts in their field, as they're trying to figure out, like, what is the role of race in all of this medicine that we're doing. And it's been great, because I just sit there and they're like, are we doing it right? And I'm like, you're the experts. And they kind of wrestle with it and come up with an agreement amongst themselves. But really, when you start talking about these concepts, it seems like lots of people are coming at it from very different perspectives, and there's a lot of confusion. So this is something that we have a lot of work to do. So the first area is language, being mindful of language, attitudes, and behaviors. So eliminating the use of outdated, imprecise terms like Oriental and Caucasian. Interestingly, when we first put out this exact curriculum, we used the word Caucasian, and that was 7 years ago. So now we took it out, and, becoming more aware of the role of that word in, kind of how that word came to be. And so it's not a word that's used anymore. or trying not to use it, but it just shows how quickly language is changing. And then using first person language. This whole concept of first person language came from the disability advocacy movement in the 70s, and is really very powerful. So really thinking about or trying to talk about people as a person with an illness rather than a person defined by that illness. And I have to say that out of all of these concepts that have changed my personal life, thinking about members of my family who have issues with alcohol, not as an alcoholic, but as a person struggling with alcohol dependence, has actually really helped me. So it's a very powerful concept. I want to just thinking about why these words and messages matter apart from, our personal experiences. And this is again a drop in the chat. Samantha, if you could drop this link in the chat. This is an amazing document put out by the AMA and the AAMC. It's like 56 pages long. If you just read the first couple of pages, it has, I think, the most salient topics. You don't actually have to read till the end, although I did, and it was very interesting. But so they really talk about like, why does this language matter? It's not so much that we have to be correct every time, but it's really about a narrative that we're creating. So we have these words and messages. They lead to the words lead to stories that we build and that we share, and then those stories lead to a narrative and a deep cultural and societal values that we all share. And so it really is giving us a sense of how each of us can, by small changes to language, have this kind of radical effect on our culture. Kind of like one person turning off a light in a room and saving energy. So highly recommended in terms of really why we're thinking about language, and it's really not about being woke, but about shifting the narrative. And so this is just a screenshot from that document. So it's really nice the way that they set it up. So they just have like commonly used terms and phrases, and then they have an equity focused alternative. So we go from underrepresented minority to historically marginalized, minoritized, or excluded, and then they give a reason. So to be underrepresented, one is not enough or below. The term URM unnecessarily aggregates and confounds the experiences of diverse groups and renders invisible the processes that lead to exclusion. So we're really moving from this passive or static language to a more active language that takes into account a broader set of actions that put this our current situation into effect. Just a quick note, this is another drop in the chat link. The CDC also has health equity guiding principles for unbiased and inclusive communication that might be interesting or useful, that are interesting, useful. Second is, and this used to be our number one because this is really where this whole effort started with the students. So being inclusive in representations of healthy normal, these particular students were in anatomy class and they were being taught that healthy gums were pink. And when they looked in the mirror, they thought their gums were healthy, but they really looked more like this and they had pigment to them. And so they went to their anatomy professor, who was really delighted to learn and change. And now this is the slide, rather than this was the old slide. And now the slide is, you have both here. And then the next is being inclusive in representations of pathology. As a pediatrician, this was really mind-blowing to me to think about the APGAR score, which scores babies on being pink. And I have, done this my whole life and never thought about how are we going to see hypoxia in a darker skinned baby. I was never taught how to do that. So really starting to think about how we can do that. Also just in terms of hyperbilirubinemia. Another even more ubiquitous issue is showing slides of diseases or diseases on skin of color. And this was another area where I looked back at my slides, and all of my slides were pretty much mostly on skin of color, because I had gone where? To Google to get my my slides, and these were the types of measles slides that I had in my slide banks that I was teaching from. And whereas I've worked in Harlem my entire career, this is what measles looks like when it shows up for me, but I wasn't even including that or teaching that. It's very difficult to find this picture of this little boy. So we've been going back and helping people to find where can you find these slides with skin of color. Up to Date now has a skin of color section. So this is, you put lupus, discoid lupus into the chat, into the Up to Date search, and then you scroll down a little bit and you can find these images. And here is the all skin types, and here's skin of color. So this is a really useful tool that has just become available in the past couple of years. There's other resources, brownskinmatters.com. There's really useful skin of color YouTube videos. And again, I can send all of those around for your group. Also lots of textbooks that are coming out. And our library has kind of gotten electronic copies of those. So that's been really useful. Avoiding stereotypes in representations of pathology is another. So really trying to avoid strengthening stereotypes. Some examples are if you only talk about STDs with men who have sex with men or young people, or whenever you're talking about traumas, you're only talking about people of color. This is a really useful tool. It's called the Upstate Bias Checklist, and here is the link. I think this is one of the links, Samantha, that we can put in the chat. And there are other articles that talk about how to create teaching cases that are more inclusive. And this comes up again and again. Exploring structural reasons for differences in health outcomes. To illustrate this, I just wanted to point out there's a really, really useful recent article that looked at the use of race in pediatric clinical practice guidelines. As far as I know, I haven't seen a similar one in the other disciplines, a similar review. But the authors reviewed 414 pediatric clinical practice guidelines to look at how we are using race in these guidelines that we all use. And so their conclusion was that race was frequently used in ways that could negatively affect healthcare inequities. It's a really nice article because they give concrete examples of how we can do better. This is the table from the study. So they pointed out ways that race was positively used to impact health inequities. So race used to describe a disparity, race used to describe inclusivity, et cetera. And then here, how race was negatively impacting health equities or perpetuating structural racism. So, and this was 57% of the articles, normalizing the majority group or centering whiteness, conflating race as a biological risk factor, conflating race with a negative stereotype, conflating race, ethnicity, and genetic risk, and then establishing testing or treating thresholds or using racial coefficients. And finally, just talking about acknowledging to our students the limitations of research when we're presenting research. So examples might be, acknowledging that in a study there was an underrepresentation of minoritized groups, or studies may frequently conflate or confuse categories. For example, Africans versus Nigerians versus African Americans versus Black people. All of these are very, very distinct and different categories. And our kidney folks, our renal folks have really taken an innovative step in using the controversy around GFR to help to encourage students critical thinking. And so, using a case and really walking through what are the decision points and why, and helping them to think about how we create these best practices for medical care. This is an example of how we present data around race and ethnicity. So this is an example using COVID cases. So if you just present here, this chart with disparities, so Alaskan American Indian, Asian, Black, Hispanic people having these various death rates, if you don't go the next step, which the CDC does do, to say here in this, so here I had this black orange, but here it comes in, race and ethnicity are risk markers for other underlying conditions that affect health, including socioeconomic status, access to healthcare, exposure to virus-related occupations, such as frontline workers, essential workers, and critical infrastructure workers. So this addition is really crucial to explaining to the population, to our students, and not blaming the groups that are suffering from these disparities. So just, we rolled out these guidelines in 7 years ago, and then we went back in 2000, 2 years ago, and surveyed faculty and said, are you aware of the guidelines? Actually, most people were, and this is an N of about 25 faculty, but have you used the guidelines? Most people said no. And our faculty indicated the barriers of awareness, time, and skills. And so actually a student thought of the idea of creating this slide that we now use for all of our preclinical lectures, and are moving it into the clinical arena. So this is our statement of partnership and humility that all faculty put in their slides. And it says, in the service of increasing equity at VPNS, I have considered the VPNS guidelines for promoting an anti-bias and inclusive curriculum in creating this lecture. I invite your feedback in promoting equity within this learning space. So really that's this, lifelong learning. We're modeling lifelong learning. And if you have suggestions, please email me or enter feedback on the Anti-Bias Inclusive Curriculum Feedback Portal. And when we talk about setting up an environment, a non-punitive, supportive environment for growth, I think this slide combined with the portal and the guidelines has really been our most effective tool. And then when the feedback is put into the portal, I'm the one who goes back to the faculty in a non-punitive way, not to the faculty, but to the course director, and says, what are your thoughts about this comment that the student had, and how can I help in any way? And for the most part, our faculty are very, very receptive. I can say that sometimes folks are anxious at the beginning of that conversation, but at the end, people are really grateful and open and making changes. And one wonderful episode that happened a couple of months ago was that a course was cited for a second time for having, not having a lecture, not having slides with skin of color. And when I went back to that course director, he said, I gave a talk to, we did faculty development for all of our department, but that one person was absent that day. So I think the message is getting through, and it's a great partnership. So I want to just jump in the last couple of minutes to talking a little bit about what we're doing in terms of our curriculum revision. Oh, great. And you have access to Visual DX directly as well as to UpToDate. So that's fantastic. Wonderful. Thank you, Deborah. So if we can just drop into the chat the AAMC competencies. So we started thinking about our curriculum goals, looking at the AAMC DEI competencies, and they were in draft form for a long time, and they're finally out, and we put in the link. So we developed, based on those and kind of what we were using before, which was the TACT cultural competency learning objectives, we developed 10 anti-racism learning objectives, and I won't go through the 10, but I'm happy to send them, and they're still in draft form. But these are the domains that we used. So demonstrating the value of diversity, developing historical consciousness, C is really thinking about health systems and solutions. And then D is advocacy, so really moving to action. And I'll talk a little bit more about these and partnering with communities. So we looked at preclinical arena, clinical, and fourth year. And as you're probably seeing a lot of spirals if you're working on curriculum reform, we're really thinking about how to reinforce these concepts throughout. And I think this is a big difference because for the past many years that I was involved in this work, we were really focused on a piece of content here, a piece of content there. You know, we'll learn about implicit bias here. We'll learn about microaggressions here, but not really thinking about how to spiral and develop skills over time and what we would like the final graduate to be able to do and how we're going to get there. So this is an example of learning objective 1, understanding the role of self-awareness of bias in self and others. So in the preclinical, we're talking about what is the concept of bias. The students are taking the Harvard IAT and reflecting on it. And then we're talking about research that links bias to racial and ethnic health disparities. In clinical years, students are asked to demonstrate an awareness of personal bias on patient care. And then fourth year, strategizing, demonstrating that they have an ability to strategize to mitigate effects of personal bias in clinical decision-making and the delivery of patient care. And that might be even thinking about like how race, use of race in the one-liner has been shown to increase bias. Learning objective 4, understanding the distinction between race as a social construct as opposed to a risk factor for disease and racism as a cause of healthcare disparities. So again, in preclinical, articulating that race is a social construct and racism as a cause of healthcare inequities. And this is going on, we have in genetics, nephrology, pulmonary, cardiology in various ways. In clinical, being able to name examples of race-based algorithms in medicine and consider the implications for evidence-based medicine. And in fourth year, articulating an awareness of the controversy of genetic ancestry versus race in medical algorithms. And this slide is to remind me to talk a little bit about curricular mapping. So our fellows and myself have been kind of making the rounds on a listening tour with the directors of our clinical clerkships with our anti-racism learning objectives in hand, and letting them know what's going on in the preclinical curriculum that they can build on, and asking them, you know, if they're already covering some of this content and how they might want to think about covering it. And usually the conversation starts with, we're so busy, like our curriculum's so tight, we can't do anything else. Lots of overwhelm and anxiousness, but for the most part, you know, frequently we're able to articulate a small area. And we just met with anesthesia last week. It's, you know, they were like, we're only a 1-week curriculum, but they decided that they wanted to help the next generation of students understand how to interpret pulse ox measurements and dark skin tone. So it's a very specific goal that's very relevant to their area. So just to end, I love this slide, which many of you may have seen, you know, with this apple tree, maybe fruit tree here. Inequality is when there's unequal access to opportunities. All the apples are over here, no apples over here. Equality is when you give folks the same ladder, but still this person over here has fewer apples on their side. Equity is when you start to customize tools to identify and address inequality. So some people might need a bigger ladder. And then justice would be fixing the system so that then the apples are distributed and everybody can have the same ladder there. So, hey, almost right on time. I'm very impressed with myself here. So happy to take questions. I'm gonna stop this share here.
Thank you so much. That was really like a tour de force of an incredible amount of information and resources and things that I could already think of 100 different ways, and then some that we can probably utilize. So thank you. And it's great to know, thank you, Debbie, that we have access to so much. So if people have questions, if you want to sort of indicate with a hand raise or drop your question into the chat, we can go through questions. We certainly have time for questions. And let's see, it looks like, okay. So while people are thinking about their questions, maybe I'll start with one. As you were sharing the portal that you have, I thought that that slide that you showed that the faculty are incorporating, what was it? To build it into the statement of partnership. I thought that was really beautiful. And it was good to hear kind of how you receive the information through there. I'm wondering also if you receive feedback through that portal about things that we as faculty may inadvertently say during a session, apart from just what the slides are, or maybe an interaction that happens. We do a lot of interactive sessions and dialogue. And then how do you kind of handle that, and any sort of best practices that you found to be effective in kind of sharing that back with faculty?
So that's a great question. So just for information, that portal is linked to our harassment and learning environment, mistreatment. So students have the opportunity when they come in, they can choose bias or they can choose, mistreatment. And then our Center for Teaching and Learning folks look through those and kind of make sure that they're classified in the right way. Sometimes they might move one over or move another over. In terms of comments, yes, we get lots of feedback on comments, things that may be said on rounds. I'm thinking of, just someone saying maybe sicklers versus a person with sickle cell disease. Sometimes the comments get very subtle. There was a really interesting comment where a student was pointing out how in the NICU, a faculty member was encouraging students to think about the reason why they needed to test the patient for a genetic issue was because of the name of the patient, right? So, and really trying to get them thinking, this part of the world has a much higher incidence of consanguinity, but really, yes, you could still make that point, but you could also make the point that if someone has multiple birth defects, that's a moment to think about consanguinity or a genetic issue, right? So and the student was kind of making this very subtle point that we don't want to be taught, which I think actually we were taught, this reflexive way of approaching patients, right? Black patient, think of sickle cell, patient from this particular, white patient, think of CF, whereas, most of our patients with CF up at our hospital are very dark. So really trying to help to think about, like, what are we teaching? It can't be just pattern recognition. And also we don't want to be supporting stereotypes. How are we teaching critical thinking to our students? So yes, we do get lots of feedback about more so comments that are made in passing. Other ones are like that we've gotten, I'm just thinking recently, and this is something that we all do, calling something crazy, psychotic, using mental health terms that are stigma, that are not, that add to mental health stigma. How do we talk about people with overweight issues? So just lots of, and the students are amazing. I mean, one of the things is also just thinking about inclusion with relation to sex and gender. So they give us a lot of feedback. So, but then when taking it back to the faculty member, I think that that's a really important other piece. We don't want to just go back and penalize or, just call somebody out necessarily. But so that's why we go back to the course director who knows that faculty member and who can think about the environment. Because anytime you have a microaggression, you also have an environment. And so we also have a feedback portal in pediatrics that we just developed this year called, it's pedsbesafe.com. If anyone's interested in the GME space, pedsbesafe.com. And so that's a portal that we have just for our house staff. and they can put in feedback there. But we very much didn't want to get into a tit for tat with the nurses. Or so what we do is we take the comments, very similar to what we do in the medical school, and then we think about what are the structural pieces that we can put into place. Is there more education that we can do in one area or another without targeting necessarily somebody? Sometimes, yes, the feedback will go back to the person if we think that's going to be useful. But in general, especially in the hospital space, we're really trying to more so heat map and kind of say, is this an area that we're getting a lot of concern about? What can we do? What can we go in there and do to help with that? So I hope that answers your question a little bit.
Yeah, absolutely. Thank you. It's such a challenging and really important way of, kind of capturing what's happening. I love that idea of sort of heat mapping things and trying to think about which areas might light up. That's really, really helpful. So let's see, we have a couple of questions right now in the chat. So why don't I share some of those with you? So the first one is, what tools do you find are effective to equip students to continue fighting for justice once they graduate in a system that may retaliate?
Oh, that's a great point. Dr. Jean Marie Bradford, who's a close colleague, she's developed an upstander curriculum, a 4-year curriculum, to help students to think about action, particularly in the area of microaggressions. And this way of thinking about microaggressions as an upstander skill, I think was a really important innovation for her to come up with, in that it's something that everybody can engage in. So, the students who have been target of microaggressions, the students who haven't, everybody can be an upstander. So it moves a little bit away from our students having to talk about their own microaggressions and potentially re-traumatizing them. So instead, we talk about all real spectrum of microaggressions, and then how would you respond as an upstander? And so then everybody's kind of on a similar playing field. In addition, what she does is when we do have those conversations, we allow students to opt in to an affinity group. So any student who has experienced microaggressions, if they want to, can opt into an affinity group discussion section. So I think that's been important. We didn't want to say, it took us a while to figure that out, like, having it be an opt-in and then it can be like a group of students who are sharing. So that's really been crucial in terms of, and so in those teaching opportunities, we're giving them lots of different tools that they can use to speak out and to advocate for themselves or for people in their learning environment. But also, like, a lot of it is discussion based, like what would be the reasons why you might not speak out, and then really helping them to think about many different levels of response to a microaggression or to something that you see, and helping them to understand that even naming it, I mean, that's something we didn't have, right? I know folks here, like, folks who've been in medical medicine for a while, like, when we came up, there was nothing, right? We didn't even have a name for it. So, even just naming it, thinking about it like, oh, I didn't deserve that, but, and then B, even just going to one other person and talking about it is a step. Many of us, experienced these and just kept them in and never talked about it. So, action is not necessarily, just going to the dean or the papers or whatever. There's many different steps along the way. But then in addition, we've built in, and so I think that a critical piece of our curriculum, these anti-racist learning objectives, is that each one is action oriented. So it's not enough to have that knowledge and the attitudes, but really it's about having the skills. So we're having students learn how to write an op-ed, think about ways. And so as a graduation competency is that you need to demonstrate like how you can influence the environment that you're in towards equity. I hope that answered the question. If not, maybe feed it back in again.
Yeah, thank you. Absolutely. And definitely also just to mention, there's a lot of appreciation and thanks in each of these comments as people are putting their questions in for you. So the next question is, I'm curious about how you've incorporated advocacy, which you've spoken a little bit about, into your health equity curriculum, as well as some examples of how you are assessing students on their knowledge and skills in this area.
Assessment. Assessment is the hardest thing, and we're not there. Actually, I was talking to Rebecca Doherty. She's sent something that she's doing with assessment, which we're really grateful for. She's adding a piece on the student write-ups that has to do with social determinants of health. That's like the biggest thing that we're working on, and we don't have a lot yet besides reflection and discussion, participation. We are developing right now in our primary care an actual reflection rubric, so around structural competency. So I think we're aware now that our students are getting a really solid foundation in structural competency in the preclinical years, and then in some of the rotations. So we are developing with some folks at Monty and elsewhere a rubric so that students will be graded, and it will be a portion of their grade to demonstrate that they're able to write that. But again, the way that we're developing is like, we're going to give them the rubric, so check it out. You can submit it once, it can be looked at by, peer probably, and then you can submit it again. So, the idea is that everyone will get their full points, but students will need to demonstrate that they understand that concept and they're able to craft or critique an action that can be taken to change structure.
Amazing. Thank you.
But if anyone has any ideas, love to partner, and already partnering with Rebecca around this. But I think that's what we really need to do, because if it's not assessed, students don't value it, and it's really important also for our precision too, and our pedagogy, to think about what is it that we're talking about, and how can someone demonstrate that.
Mm-hmm. Yeah. Actually, Rebecca had put some of this in the chat as part of the question, so okay. you lined it up perfectly. Okay, we have another question. Thank you for your presentation. You mentioned you're moving more towards competency-based curriculum, and could you talk a little bit about how you plan on incorporating anti-racism into that new competency-based curriculum?
That's a great question. Dr. Lipson, who is my boss and our vice chair for education, is kind of hammering it into all of us, basically. So some tools that we're using, backwards design. So really thinking about what do you want that graduate, what do you want that person at the end of your rotation, at the end of your course, to be able to do, and then working backwards from there. First, what do you want them to be able to do, and how are you going to assess it? And working backwards from there. So there's a lot of good. I'm happy to send some literature on backwards design, but that's really what we're working towards. But I have to say, I'm fairly a novice in this area of competency-based education, and I think many of us are. We think of content, we think of things that we want a learner to know, before we think about how they're going to put that into action as a competent physician graduate. And that's really what we're working on now, and that's where these learning objectives. And we kind of went through a lot of iterations on that. It's like, okay, that's not specific enough. What is it that we can assess? What is it that we really want them to know and to be able to do?
Yeah, I think a lot of us feel that way. We talk about competency-based education a lot, but still feel like novices because it's challenging, right? It's if it were easy and straightforward, there would be a quicker path there. But it's that holistic piece that's kind of hard to break down sometimes.
Yeah.
So another comment and question. Thank you for this discussion. Once the statement of partnership and humility was given, did you create another survey or receive feedback of increased awareness? And did people actually start using the slides? Data supporting a non-punitive approach is effective.
That's a great question, and the answer is no. We have not pulled more data, but what we did do was we rolled it out first as an option, and some people took it up, and then the faculty decided to make it mandatory, and then 95% of people took it up, and then the students put in the chat. Now, this faculty member didn't have the statement of partnership and humility, and so now the students are asking for it. So what can you do? We all answer to our students. So it is pretty much 100% in our preclinical now, and I can just say anecdotally, like we don't get the same feedback from the students repeatedly. We get the feedback usually once. We go back to the faculty, and then they fix it. They put for the most part they put the feedback into operation, because for the most part it's good feedback.
Just, I guess something just taking a related note off of that before we go to the next question. Do you see a difference? There's so much energy and wonderful conscious effort in the preclinical curriculum, it sounds like. And do you see a big discrepancy, between when students are in the clinical space and when they're in the preclinical curriculum? And, I think it's probably something a lot of us are struggling with. How do you kind of work through that? Do you talk about it explicitly with them? How do you address that?
It is really tricky, because there's just, as there's thousands of faculty who are, engaging with our learners. If not thousands, maybe hundreds, a lot. But it's gradual. I'm just thinking, I was just when we did our rounds with the faculty recently, with the clinical clerkships, we're just saying, oh, so what are you doing? Can you show us your materials? And one of the faculty members had the partnership slide as an attachment in the initial introductory email that was sent to students. She was also giving them 2 lectures. And so I was like, oh, are you putting the slide in your lectures as well? So she's like, no, so I was like, that's an idea. So it's a little bit more gradual, so it's kind of it's trickling out, but she was like, that's a great idea, I'll do it, but so we're working that way. Yeah, but it's, I think, getting that out. Also, just like we decided, I think our faculty as a body decided that we wouldn't use race in the one-liner unless there's a reason to do so. And so that kind of faculty development went out to an initial group of course leaders, but it hasn't diffused down to everybody. So, things like that, that we're trying to slowly get the word out. The other big piece, just talking about competency-based education, I think a big part of competency-based education is that students need to feel trust and belonging in the learning environment, right? And so assessment and just grading in general, never mind assessment about the anti-racism learning objectives, but just assessment in general is a big issue. And we have, I think everybody, there's bias in our assessments. And so that is, I think in the clinical arena, that's our biggest push right now, is moving towards our faculty being able to give feedback that is behaviorally based and competency based. We're very far from that. And I have to include myself in that. How many times have I written a pleasure to teach, that kind of thing, which really doesn't say anything, right? Except that they were nice, they had a nice personality, but doesn't say anything about their competency, or little. So that has been our biggest push, and it's really revolutionary, just to go to pediatrics, to go to surgery and say, what is it that you want the learners to come away with? And what's your definition of an honor student, right? We all kind of like, I don't know, but I know it when I see it, right? We all came up that way. And so that's really been our biggest push. I don't know if you're aware of like the Northwestern has this, Feynman School of Medicine has this really brief 10-minute bias in assessment module. Are you using that, Samara?
I don't think so.
Yeah, it's really nice. I can definitely send it. It's 10 minutes, which is amazing, and it's so good. Just in terms of like really zeroing in on what we're talking about. We're talking about instantiated or behaviorally based feedback. So,
That would be great if you could share that.
yeah, for sure.
I have not heard of it. I don't know if others are using it. Okay, we have one more question in the chat, and then I saw a hand go up. I don't know, Rob, if you were intending to raise your hand or not, but I'll come to you next in case if you are. Is it possible that some of these interventions might be interpreted as artificial to minority or minoritized students? And how do we ensure that they are natural and sincere?
I don't think we can ensure that they're natural and sincere. I think that they're very unnatural, because talking about race and kind of dissecting our own profession and how we've been doing things, I think it's very unnatural in a lot of ways. Like, we came up in the apprenticeship model, and you do what you were taught, and it's been shown, like, we do so much the way we were taught. So it's really, as Camara Jones has a great YouTube where she goes over different allegories, and she talks about the conveyor belt that we're all on, and turning around on that conveyor belt and walking the other way, and then fiddling with the mechanisms of the conveyor belt. It's not natural at all. And so I don't know that it has to be natural. Sincerity, I think, is related to trust, and trust is really tough. When I think about these feedback portals, when we were developing the ones in PedsBeSafe.com in the pediatrics, there were some of my colleagues who really wanted a kind of zero tolerance, like a report. Many of my friends of color, and not of color, like just in general. And that's a way to go. It's not the way that I think is the most useful, because I think people shut down, and I've seen it again and again in students. If the dialogue is not there, I mean, it's really like we're trying to convert people in a way, and bring the most people into our camp. And I think we do that the best by not. I mean, if it's egregious, I mean, if there's egregious issues, then obviously, then you go that way. And there is a hostility and mistreatment arm, of our reporting system. And if something comes in PedsBeSafe.com, that has to go to human resources, then it goes, right? But up until that point, I think trying to bring people into the tent is really useful. But trust is an issue, and I think we're struggling with that. I think everybody is struggling with that. Some of it has to do with publicity, even, like, of the things that we are doing or that you're doing. A lot of times students can't see what happened before and all the changes that have gone forward, and then they may think we're not doing anything. Dr. Lipson recently did a town hall with our students that kind of had a "you said, we did," and that was kind of a nice way to organize it, to increase trust. Bringing students into the process, I think, has been really, really helpful. I do like our model of paying students to be involved. I think that's helped increase trust, but making sure that students are present at every point along the way. And then, if there are white faculty who are doing this work. I think they very much need to partner with maybe students of color, people of color, so that the trust is there, so that people can see themselves represented in the solutions, if possible. And if not possible, then to have a conversation about that. Obviously, it's not always possible because we don't have all of the different identities and marginalized groups represented in every group situation. So I hope that started to answer, but I'm happy to follow up if there's a follow up to that.
Thank you.
I just
Tom?
have a quick comment. I guess, and I've said this before, when I look at television today, every commercial has either a minority couple or a interracial couple, and in a very artificial environment. And to me, it looks very fake. And I guess that's where I kind of think of, do we, to make sure we don't do something similar, that students perceive it as being something we're expected to do as opposed to something we really feel we want to do.
Thank you for that point. I mean, I guess the flip side to that would be that for so long there weren't interracial couples and minority folks on the commercials. So to me, when I see those, I'm just happy, I'm like, oh, that's great. So I think sure, it can be artificial, but if you create a slide deck, of a surgery slide deck, and you take the extra time to go to, let's say, Pixabay and type in, diverse team, and so that then you have, people of all different, walks of life on that team, and you have those pictures throughout your presentation. I think that the learner is going to think, wow, that person made the effort, and even if they have an all white team, they're visualizing a future in which there'll be all different types of people around that surgical table. So I think and that's something that comes up frequently with faculty. They'll be doing a presentation like all of the people in your slide deck, they're all white. Can we change that up? Just so that the students who are looking at that see themselves in there. So, I mean, think about, 30 years ago, those interracial couples weren't seen anywhere. I don't know.
No, I mean, it's a hard question. I really loved your presentation. It's just maybe just a personal observation of mine, but you really taught me a lot today, and I really appreciate it.
Thank you so much. I mean, I think it is artificial because it's the future. In a way, it's futuristic, right? We could think of it that way. It may not be what's present, but it's what we envision. So maybe that's something.
That makes tremendous sense. Thank you.
Thank you.
I'd like to just chime in on this one. Hi, Tochi Elise. When I see those commercials, when I first started, especially the Cheerios, right? I think that Cheerios commercial was one of the first ones that had an interracial couple with the father was Black and the mother was white. And the daughter brought the Cheerios to help protect her father's heart while he was lying on the couch. And I know there was a lot of backlash about that because they had an interracial couple. But Cheerios, the makers of Cheerios, doubled down and continued to show the commercial anyway. For people around in my circle, it was so nice because it was like, oh, good, this looks like what we see in our communities, in our groups. So it was really nice. All commercials are fake, and they're holding hands and two people in a bathtub and looking over the sunset and holding hands. It's not real, but just being able to see things on TV. When I saw the couple, that just seeing. There was a presentation yesterday at the meeting, and one of the cartoons had a Sikh doctor, a doctor with the turban on his head. I was like, oh my gosh, this is so cool, So it's nice because it's like this is real. In my reality, that's real, and so seeing more of these happen, it's really for people like me. it's nice because it's like, oh, cool. They're finally showing people that look like me or the people that I know that are in my circle. So finally, you're recognizing that there are people, that are different in different roles. So I'm looking at it from a different perspective as like, oh, finally. Every time it's like you look and you say, oh, good, thank goodness, finally. We're not just being portrayed as the bad guy on TV. So it's nice.
That's really nice to know. Thank you, Toshi.
Yeah, thanks, Tom.
Thank you. I love that.
Didn't see in the chat, there were a couple of other people who echoed similar comments. Starting somewhere, any effort is welcomed by most historically marginalized groups, and that representation matters. So thank you for bringing this question up, for this discussion. We are getting close to the end, very, very close to the end. Maybe Samantha, if you don't mind, if you could drop the Woo Clap poll link in there. One of the things, Dr. Cunningham, we do at kind of the end of each of our talks is ask everybody to sort of think about what from today's talk they think that we should, hang on to and capture so that we can take it forward into our curriculum renewal as we continue to make those changes. Right now, we're in this learning and researching and brainstorming process. So while the ideas are flowing, it'd be great if people can put their thoughts in there. And then maybe just to close us out, we'll give people a minute to do that. But you could start to think about what you would advise us. You shared so much that I'm sure will be incredibly useful to us and will impact and change what we do. And then if you were to advise us, which you are, as as someone talking to a group of people that really, could say, going forward, thinking about, physicians and who will be graduating and practicing in 2030, 2035 and beyond, what would you urge us to do or make sure that we include as part of our curriculum renewal? That would be great. But maybe just give people one moment to kind of add their thoughts as to what they'd like to capture, and then we could close out with your thoughts.
Okay.
Oh, okay. So Rob Roswell did have a question. So go ahead, jump in and ask your question now, Rob, as we're kind of in between captures. We're not able to hear you yet, Rob. We'll come back. So principles to take, using images of diverse people in our slides is like envisioning the future. We are teaching the doctors of the future after all. Yes. Incredible number of valuable resources that exist. Thank you for sharing your wisdom. Rob, I don't know if you wanted to try to unmute again and ask if you had a question or a comment, or if you were just had a hand raised that you didn't mean to raise. We can skip that. Really like the slide asking for feedback about prejudice or exclusion in a lecture or presentation. Place at the beginning. It really opens up dialogue in an open way. Consider what are health equity learning objectives that we expect all students to demonstrate competency in by graduation, and where along their medical education journey they should encounter the content. Great. So Dr. Cunningham, would you share your kind of thoughts for us as how you would kind of challenge us to think as we go forward?
I think two things. Thinking about the environment and the trust, I think, is really, really crucial. There is, I mean, I have certain members of the faculty who are like my barometers, and they come and they tell me, when people are really anxious. And I was saying actually in just a meeting with Rebecca and Alice a couple hours ago, that when we first started doing this work, I had 3 experienced friends, faculty members who came to me and were like, I can't do this, it's too much. I don't have the expertise to talk about race. You got to get someone who's an expert. And then even with the slide, there's a lot of anxiety. What I've tried to help promote is that this that the slide really flips the anxiety, because while faculty are waiting, or anxious about, what they're saying, like with pronouns or gender, like whatever, if they can ask for the feedback, then they don't have to be kind of building the wall of like, oh my gosh, I might get dinged here, I might get reported. And I think that school environments that don't have a way for students to give feedback are at risk for students just taking it to the social media or whatever, so if you can invite it in and then, take it seriously, then it really flips the switch. And it also, I have to say, like, one of the biggest things that I became aware of, we as doctors, we're not that good at lifelong learning, actually, like really learning new things. We have big egos. Like, that's a defining characteristic of our profession. And I totally include myself in that. So, this idea of like, that's something we have to work on. And I think that's a good place to start. And that it's necessary for competency-based education. It's supposed to be an exploration, right? It changes the nature of what we do. So I think building that environment groundwork is really crucial. And then what Dr. Lipson is always saying, which I agree with, is thinking about assessment. And it's something that is very easy because it's the hardest thing. And I include myself in that. Like, every time maybe they're just like, well, what about the assessment? I'm like, oh, right. So we're working that way. But so I think those are the two biggest things. I do think, like, we had Stephen Brookfield come and talk, and he did a talk called Teaching While White. And I learned so much from him about how to have this conversation, how to set it up. And two things he said to us. One is that you can talk about racism badly or not at all. And the other thing he talked about was that when people of color are speaking about these issues, when white people are speaking about these issues, they're at a level of arithmetic. People of color speaking about these issues are at a level of calculus. So a minoritized, and it may not just be a color issue, just any minoritized group, and they've been thinking about this every day, constantly. And so just awareness of that is nice. You don't have to, not everybody is going to be at the calculus level, but we're all kind of moving forward from where we are. So I thought that was also a really nice kind of saying that I think has stuck with our faculty.
Oh my gosh, this has really been just an incredible session with you, and we can't thank you enough for all of your wisdom and your experience and all that you've shared with us today. We are at the end of time, so I do want to wrap things up, and thank events team, Samantha and Connor and Mimi and Elizabeth and everybody for helping put today's session together, and for all of the participants who are here today. We really appreciate you, Dr. Cunningham, and all the work you're doing, and I'm sure we'll be looking to have further conversations with you as we go ahead in our curriculum renewal.
Thank you so much. It's been